The effect of this is heavily exaggerated when patients read articles by the physician. We tell them they are specialists, and they read that we still need controlled trials. We still have inconclusive evidence. Most of these interventions are palliative. We don't really know that long-term survival is really long-term survival. These are just predictions. So most patients, or not most patients, many patients are lost to this treatment because of the confusion or the contradiction in information. So something needs to be done to publish the evidence, to communicate with the public, and make a convincing case to the patients. Outside medical journals, there is still lack of information out there. And I hope that meetings like this one, in the presence of at least 3 patient support groups, there is a PMP Research Foundation, Mr. Jerry Klondowski, there is the PMP Awareness, Ms. Mina Bubecki and Mr. Scott McCartick, and COI Group for Peritoneal Surface Malignancy, which I represent. And I think communication with that kind of patient support group might facilitate a lot of that miscommunication that takes place. So now our patient knows that they have what they have and what they need. They have to find themselves as specialists. In some countries, it's not a tricky business. Information is out there, it's transparent, people know the outcomes of the different centers, and they have to choose. In other countries, it is not that clear. In many countries, and North America is one of them, people have to choose between different physicians, and they have no way of telling which one is better than the other. Which one is going to really disembowel them and pose them with hot poison, and which one is going to cure them and give them a good shot at the cure. And so patients feel many times very apprehensive about the treatment. The trickiness is compounded by the great variation in medical opinions. One patient could be told by one physician that they have localized disease that only requires laparoscopic surgery and there's nothing to worry about, and by another physician that they need complete peritonectomy and HIPEC. And many times, patients choose to listen to the least invasive, or to the more commonsensical, or to the thing that makes more sense to their special circumstances, and not necessarily to the most sound medical advice. And that's a big problem. So we dedicate a lot of our time in support groups educating patients about the type of questions they should ask when they meet with their physician, about the types of concerns they should raise, just to ensure that when they sign that informed consent, that they are informed and they really know what they had just signed on. But I do not want my role to be destructive of patient-physician trust, because it is the most valuable aspect of this whole treatment. If I ask you to take off your clothes, get drugged, lie down in a room full of strangers who will disembowel you and hose you down with heated poison, would you consent to that? We do that every single day. And that means that the trust we place in your hands is huge, and with that comes a huge responsibility. If this trust was based on misunderstandings, unrealistic expectations, or unfounded claims, the whole process falls apart. So there's a big, big, big role in making informed consent really informed consent. I am one of the lucky ones. I went to my doctor's clinic. He told me with clear language what I'm about to have, how long the procedure will be, what my prognosis will be if I had it complete, and if I didn't have it complete, and what his estimation of getting complete was. I was ready. I knew my faith was placed in the right team. I am cured, back to my life, fully functional, disease-free, as you like to describe us. But I often present myself as a patient. Still, 2 years after, completely clean, I still present myself as the patient. Why is it? I'm going to tell you a little Arabic joke about a father who wants his son to be a real man. And so the boy has a cat he loves and is in the care of his family. He goes up to college. A couple of weeks later, he calls home and he asks his dad about his cat. And the dad says, she ran out of the street. She was run down by a car. She became part of the pavement. Tough luck. hours, and next time I call you, say, oh, they've done everything they can, she died. Well, a few months later, the boy calls, and the father says, oh, son, your mother is playing on the balcony. I'm cured, I'm told. Every time I have a CT scan and go to collect the report and it says something I don't understand, not necessarily bad things, I feel, oh boy, here comes the balcony. We are never, ever out of the woods, at least not psychologically. Why? Well, we still need good diagnosis. We are sent home to find local radiologists to read our scans, right? Remember now, these are the same radiologists who missed the tumors when we had full-blown tumors, right? Why would we assume that they would see a small recurrence? And you tell us all the time that in all your papers that early detection is crucial to survival, especially for recurrence. There's nothing worse than feeling cut off from your surgeon and left to the mercy of your local doctors, no matter how good they are. And many times they're really, really, really good doctors. They're just not trained to see things. So what we really need is a form of proper follow-up. Because every time one gets a viral gastric infection or an adhesive obstruction, we start preparing the balcony speech